Well, we are pleased today from ICU DDR. My name is Carrie Hopkins-Iles, and we're so pleased to have wonderful Dr. Chia Francis from Nigeria here to talk to us about access to drug treatment, services in Nigeria, the challenge of the addiction workforce. And Doctor, we're so glad to have you here. And
Thank you very much.
Thank you. Thank you for all your great partnership and work with us in ICU DDR. And I will hand it over to you.
Thank you very much, Carrie. My presentation is titled Access to Drug Treatment Services in Nigeria, the Challenge of the Addiction Workforce. Next. You can see Nigeria is a beautiful country in Africa, a federation with 36 states and the Federal Capital Territory with an estimated population of over 174 million people. It's the most populous country in Africa and the 7th most populous country in the world. Next. Next. About 60% of the population back. You have to get back.
Is that good?
Yes.
Okay.
About 60% of the population of Nigeria are young people. That is, Nigeria has one of the largest youth population of the world. It's a culturally diverse country with more than 250 ethnic groups. And over 40% of the people in Nigeria lived below its poverty line. Next. The level of drug use in Nigeria. The growing signs of drug addiction in the country, coupled with increasing barriers to treatment services, has been a cause of worry to the government and the entire citizens of Nigeria. As far back as 1999, there were several available reports to show that the size of drug use in the country was very big compared to other African countries. Next. For instance, the UNODC 2011 statistics shows that in 1999, prevalence rate of cannabis use in Africa fluctuated between 4 and 14%. Nigeria has the prevalence of cannabis use at an estimated rate of more than 14%. This percentage represented the highest in the African region. Annual prevalence rate of opiate was estimated between 0.2 and 0.6. Prevalence use rates in Nigeria increased from 0.6% to 0.7%. This showed that Nigeria was hosting approximately 500,000 heroin users at that time, which is quite high. The UNODC World Drug Report 2018 showed that Nigeria has 10.6 million cannabis users, 4.6 opioid users, 2.4 cough syrup users, 340,000 ecstasy users, 300,000 solvents and inhalants users, 238 amphetamine and prescription stimulant users, and 92,000 cocaine users. The most recent report on drug use in Nigeria is the National Survey of 2018. It was led by the Nigerian National Bureau of Statistics and the Center for Research and Information on Substance Abuse, PRISA, with technical support from the United Nations Office on Drugs and Crime and funding from the European Union, and it reveals the following. Past year prevalence of any drug use in Nigeria is estimated at 14.4%, corresponding to 14.3 million people aged 15 to 64 years who had used a psychoactive substance in the past year for non-medical purposes. According to the report, 1 out of 7 have used drugs in the past year, age 15 to 64. 1 out of 4 drug users in Nigeria is a woman. In Nigeria, about 376,000 people are described as high-risk drug users. That is those that are using cocaine, those using crack cocaine, and amphetamines. And then 1 out of 5 high-risk drug users in Nigeria inject drugs. That is about 80,000 people in Nigeria inject drugs. When an individual initiates drug use, it is not everybody that will progress to the stage of dependence, but some do progress to the stage of dependence. And on this note, we have these statistics in Nigeria on people that have initiated drug use and have progressed to the state of dependency. Overall, 1 in 5 drug users is dependent on drugs. Talking about cannabis alone, 1 in 3 cannabis users are dependent. Talking about pharmaceutical opiates, 1 in 5 users are dependent. Talking about amphetamine, 1 in 7 amphetamine user is dependent. Looking at the geographical spread of substance use in Nigeria, that is looking at the level of drug use in Nigeria from the window of geographical spread. Nigeria is divided into 6 geopolitical zones. In the northwest zone, drug use prevalence is 12%, corresponding to 3 million users. North Central zone has drug use prevalence of 10%, corresponding to 1,500,000 users. Southwest zone has drug use prevalence of 22.4%, corresponding to 4,382,000 people. South-South zone has drug use prevalence of 16.6%, corresponding to 2,124,000 people. Southeast zone has drug use prevalence of 13.8%, corresponding to 1,550,000 people. Lastly, Northeast zone, where the activities of Boko Haram are very, very high. The prevalence drug use there is placed as 13.6%, corresponding to 2,090,000 people. Next. Looking at the level of drug use in Nigeria from the window of the age group, prevalence among the age group. When you look at this chart, you will discover that drug use is prevalent mostly within the age range of 25 5 to 29, and all manner of drugs are used. But the drug that is highly used, the most prevalent, and the drug that has the highest use is cannabis. Age of initiation is around 15, and it's surprising to note that even up to the age of 64, people are still using the drug. That means they have become addicted to that substance. Next. Next one again. Next. Next. Drug use habits in Nigeria have moved in such a way that young people are using a lot of substances mixed together. There is a substance that is known as gutter water. Gutter water is like a cocktail. It's a mixture of so many drugs such as tramadol, rofinol, alcohol, other liquids mixed together. And once they are mixed and used, the young people are already on high. The picture that you are seeing here is the picture of a young man mixing these substances and using them. And once they are on this, they become high, they can do anything. Next. It is also surprising to note that some young adults are turning to crude concoctions as alternatives, including smoking or pawpaw leaves. As you can see from the slide, the pawpaw plant is there. So some people pluck these leaves, dry them, and smoke them. Some resort to smoking lizard dung, the sheet of lizard. As you can see the lizard on top, they move around, they pack the dung, they crush it, and they smoke it. Some engage in drinking of a shrub known as Datura mete, as it is seen from the chart. It's a very potent drug. Once you mix and you drink it, you are on the other side of the world. Some are sniffing glue, petrol, sewage, and urine as inhalants. Next. 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 The abuse of those substances is high because those substances are available. And because they are available, young people use them. And the availability of these substances is evidence in some of the arrests that are made by our law enforcement officers. As you can see, the National Drug Law Enforcement officers, within 2 days, they arrested a sizable quantity of tramadol. Apart from this arrest, similar arrests have been made in the past to this level. As the level of drug use is increasing, definitely many people have become addicted to these substances. They have developed substance use disorder and are in need of treatment. And this is where the problem lies, because it is not everybody that needs treatment that will have access to treatment. Next. As I mentioned before, the number of high-risk drug users in Nigeria, the National Survey report revealed that 40% of high-risk drug users wanted treatment, but they were not able to get it. That means they needed treatment, but because they could not have it, they just have to live with their addiction against their will. And the study found that there are 4 major factors that were responsible for this predicament. 1, the people could not afford treatment. Second was fear of stigma. Next was treatment services were not available. And finally, information about treatment services were not available to the people. And so it was difficult for them to access treatment services. Next. Now that we have this issue at hand, I want us to look at the efforts made by the government and the Nigerian people to see that people, the citizens, have access to drug treatment services. And I want to approach this section from the historical point of view. Historical, period to 1983, patients with drug dependence received care along with other patients in psychiatric wards and traditional healing homes. Thus, the stigma and torture associated with this type of arrangement, instead of improving access to treatment services, worsen it instead. Next. 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 In 1983, however, a drug abuse treatment education and research center data was established at the neuropsychiatric hospital Arrow. This was the first treatment center based on science to be established in the country. And since then, other organizations, especially faith-based organizations, came up with similar stand-alone drug treatment centers. Next. 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 By May 2002 to June 2004, the UNODC, in collaboration with NDLA, Federal Ministry of Health, executed a project titled Strengthening Treatment and Rehabilitation Services Offered by Government and NGOs. The project was aimed at strengthening the treatment and rehabilitation of clients in selected non-governmental organizations spread across the country. Next. 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 Increasing awareness about the availability of these centers. This because previous reports showed that unavailability of information was a problem to the people. And number 3 point was enhancing the socio-economic reintegration of persons treated back into their communities through vocational skill acquisition by equipping the selected centers to achieve this objective. Next. Next. Providing adequate training for the personnel of these centers to make them more knowledgeable and efficient to render organized and effective services. Next. In line with the objectives of this project, a 2-week comprehensive training workshop was held at the Neuropsychiatric Hospital, Arrow, between November 17th to 29th, 2003, for personnel of selected centers across the country. Next. At the end of this program, there was a training that was held in order to show that there is impact. Some of the treatment centers in Nigeria have actually benefited from the training of the people that were trained. We are now looking at the impact of the project that was executed. There was training of the main selected organizations. And we are looking at it that the training was actually helpful because those that were trained initially, they executed, implemented quality service in their centers, and other treatment centers are copying from their own experience, and it has been wonderful. Next. Next. Another outcome of the project, there was production and wide circulation of a documentary on available treatment facilities in the country. This made information available to clients seeking help for their drug use problems, as well as enhance the referral of clients by healthcare providers in the country. Next. 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 The donation of equipment to the selected centers has also helped to improve the quality of care, as well as provide skills for income generation for some of the clients, thereby making their socio-economic reintegration into the society much easier. Next. 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 Change in client management methods, such as designation of separate wards or units for rehabilitation purposes, unlike the previous practice of putting them together with the non-drug related psychotic patients, increase recreational, motivational, and other interactional activities with less resort to use of medications became a common practice as an outcome of the project. Next. Patronage of the treatment facilities by the neighborhood for purpose of skill acquisition, and AK in particular, contribute to help to destigmatize these institutions. Because those institutions, people look at them as institutions where people who are living there, who are making use of them, are out of their mind. But because of those facilities, people going there for services, their perception about the institution was changed. Next. Next. Another related intervention that has assisted access to drug treatment services in Nigeria is the UNODC project titled Response to Drugs and Related Organized Crime in Nigeria. Under this project, a number of guidelines were developed and capacity building programs for service providers carried out. Developed guidelines include some of the following. Next. National minimum standards on drug-dependent treatment in Nigeria, standard policy and practice guideline for NDLA counseling centers, These are some of the guidelines that were developed. On training, treatment, and other services. Over 1,000 service providers from hospitals, NDLA counseling centers, and CSOs have been trained on treatment package in the country. Next. A pilot drug treatment center has been set up in Kuje prison in FCT Abuja. This is to ensure that treatment is made available to people who are residing inside the prison. Next. Also, set up is 5 drop-in centers in some states run by CSOs. Furthermore, a referral network for treatment of substance use disorders in Nigeria has been established. Next. The Nigerian Epidemiological Network on Drug Use NENDU, with a focus on monitoring treatment demand and drug use trends, was also established in 2015. For now, NENDU covers only 11 major hospitals and 7 commands of NDLA. In another giant stride to assess drug treatments in Nigeria, a hospital in Nigeria signed a memorandum of understanding with the Colombo Plan, and by 2017, the Colombo Plan introduced UTC in Nigeria with the first training of about 30 national trainers at Yaba Psychiatric Hospital, Lagos. Next. Next. Following the training, the national trainers extended the training to their various organizations and beyond. The outcome of this development is that more and more people are being certified as addiction professionals in UTC, and their training is yielding positive impact on treatment methodology in their treatment settings. One of the latest efforts aimed at ensuring that drug treatment services are accessible by Nigerians is the launching of the drug help net. Following the outbreak of COVID-19 in Nigeria, the UNODC in Nigeria launched the drug help net. This is a network of Nigerian doctors, psychologists, nurses, and counselors to provide over-the-phone assistance to drug users or their families who need such services during the COVID-19 period. This was after the personnel were trained and certified under the project in drug treatment using the treatment methodology and or universal treatment curriculum, UTC. Next. Despite these efforts aimed at ensuring that Nigerians have access to treatment services, there is public outcry against inability to access drug treatment services. This is common in our national dailies and other discussion settings. It is in view of this persistent public outcry that the present study was carried out. Next. The present study has the following objectives: to determine drug treatment services providers' perception of access to drug treatment barriers in Nigeria. You know, from the report that I have been mentioning and citing, data was collected from treatment seekers. This study therefore decided to seek to collect data from service providers to see how the information can be compared on factors affecting treatment services in Nigeria. B, to determine those involved in drug treatment in Nigeria. And C, to determine the level of professional certification of drug treatment service providers in Nigeria. In order to achieve the objectives above, 34 participants were sampled for the study. Male 18, female 16. They were treatment service providers attending UTC 6, 7, and 8 training at National State University, Kefi, Nigeria. Data collected from them revealed the following. Result of the study. First, barriers to drug treatment services. From the service provider's point of view, we have the following barrier factors. Lack of trained workforce, 16%, which is the highest. Ignorance to lack of awareness of existing treatment services, 13%. Poor physical infrastructure of treatment centers, 13.1%. Cost of treatment, 12.0%. Social stigma, 12.0%. Clients denial, stroke unwillingness, 11.42%. Lack of community support, 10.9%. And superstitious belief about substance use disorder, 10.9%. Next. 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 On the question of who is involved in treatment in Nigeria, the service providers presented the following data. Psychiatrists, 9 people. Psychologists, 18 people. Medical doctors, 9 people. Nurses, 9 people. Social workers, 7. Counselors, 1. Next. On certification status of treatment team members as at March 2020, we have the following data. On UTC, from the center studied, it's only from BSH that we had a staff that has completed a UTC training and has taken exam and received certification. On treatment certification, in all the treatment centers is nil. On other professional certification bodies is nil. Next. Discussion. From the point of view of the service providers, shortage of trained workforce in drug abuse treatment is one of the topmost barriers against access to drug treatment services in Nigeria. This finding is supported by the National Survey Report 2018, which states as follows. Very limited national capacity to provide scientific evidence-based treatment is among the most powerful factors hindering access to drug treatment services in Nigeria. Next. The findings of this study further showed that lack of awareness of the existence of evidence-based treatment services, poor physical infrastructure, high cost of treatment, and social stigma are additional barriers to drug treatment services in Nigeria. In the NENDU report of 2015 to 2017, where only a total of 3,119 drug treatment episodes were recorded in a population where 14.3 million people are drug users may not be unconnected with the barriers hindering access to drug treatment services in Nigeria. Next. The study found that addiction treatment workforce in the center studies is made up of professionals such as psychiatrists, psychologists, medical doctors, nurses, social workers, and counselors. While the researcher did not intend to discuss deep the issue of science of the addiction workforce, because it may be related to the size of the center studied. The study found that the size of nurses was the highest. This was followed by psychologists. This trend is similar to findings of previous studies such as Unifade 2011. In most centers studied, social workers were not found. The death of social workers in treatment centers in Nigeria is partly due to the fact that only a few universities are offering this course. In addition, in the few universities where the course is offered, students are not exposed to drug treatment issues sufficiently, as Nigerian universities are not offering courses in addiction treatment currently. That is, there is an existing gap between social work knowledge and addiction treatment and rehabilitation in the country. On the issue of professional certification in SUD treatment, the study found that in all the centers where the participants are working, no staff has any certification in SUD treatment except from BSH Treatment Center that has a record of a staff completing training in UTC. The participants for the study were therefore pioneering staff undergoing training in UTC with the goal of getting certified in the nearest future. Next. Limitation of the study. The addiction treatment workforce that participated in this study is small, such that it cannot be a representation of the addiction workforce in Nigeria. The participants were just a group of SUD treatment staff in different treatment and rehabilitation centers who turned up for IUTC training at National State University, Kefi. Their characteristics and that of other SUD treatment staff in other parts of the country may therefore not be the same. To generalize this study, therefore, there is a limitation. Conclusion. This is one of the first attempts to examine the issue of addiction workforce in Nigeria. The study revealed that addiction workforce constitute a challenge to access to drug treatment services in Nigeria, evidenced by its low level of professional training and science. In view of the above, the following recommendations are made. 1. Courses leading to professional training in SUD treatment should be introduced in high institutions of learning, such as School of Nursing and universities in Nigeria. This is to produce sufficient addiction workforce. Next. Efforts should also be made to see that a system of taking a CBT UTC certification exam is introduced in Nigeria. This will address the challenge of people completing training and waiting indefinitely for UTC paper and pencil exam, especially now with the COVID-19 pandemic, that moving from one country to another is difficult. If the online exam is introduced, it will help the situation. Updating the list of treatment and rehabilitation centers as initiated by the UNODC project and posting such on the net is a necessity. When the above is done, not neglecting other essential necessities, there will be a boost in the science and professional capacity of addiction workforce in Nigeria, and information on addiction treatment centers and services will become more readily available to the people. Consequently, access to drug treatment service will experience a significant boost in Nigeria. Thank you.
Okay, thank you so much. We learned a
Yes.
lot. So we have a few questions. The
Yes.
first is, what is the national minimum standard and what does it entail?
Okay, thank you very much for that question. You know, before now, people were just treating or undertaking treatment in their own way, the way they see it. The national minimum standard is a document published. It entails having a uniform standard, a standard that is accepted worldwide, a standard that is humane. There are some issues in this document, a lot of them, but time will not permit me to mention, but I just want to mention a few. One, the document states that on the issue of physical infrastructure, there should be bed, there should be cabin, there should be AC, there should be space, there should be recreational activities. In the document, it stated that clients should not be forced into treatment. It should be on a willing basis. And the duration of treatment is stated there. The longer, the better. At least a minimum of 3 months is stated in the document. The document also states that if a client comes in, there should be an assessment, and treatment plan should be based on assessment. And in doing assessment, there are documents that are listed there, evidence-based assessment too, such as the who assists, the ASI, the Addiction Severity Index.
Mm-hmm.
You know, these are the things that are in the document just to see that clients are treated as human. Clients are not forced following the international standards. Thank you.
Thank you. So one of the other questions we received is, what are the factors mitigating against having sufficient addiction workforce in Nigeria?
Thank you very much for that question. In Nigeria, there are so many factors affecting raising sufficient addiction workforce, but as I said before, for time factor, I will just mention a few. One is lack of trainers. Lack the manpower to train people is not enough. Like if you want to have qualified students, you need teachers. It's the same thing with addiction field. For us to have qualified manpower, we need qualified trainers. So we are lacking qualified trainers who can now train people. Is a serious challenge. As I mentioned before, we don't have institutions, so we have few trainers. Like when the Colombo plan came, the national trainers were 30. And okay, you can see the population of over 174 million people. And now you are having 10 national trainers in UTC. You know, it is highly insignificant.
Yeah.
The second factor is what I call institutional factor. You know, our universities in Nigeria, they are not offering any course in drug treatment. And universities are the ones, if I'm told they are training people, they are bound to raise sufficient workforce. But since up till now, that is not the case, it's a challenge. And the challenges of the universities too is because of lack of those who can train the students. Because for you to train people undergraduate, you need people that have masters in addiction science, they are not there. For you to train people at the master's level, you need trainers that have the PhD level, they are not there. So the universities themselves are having a challenge. So there is this institutional factor, it is there. Number three is what I call fear of tomorrow. You know, addiction treatment is something that is new. And so those that we are calling them to come into addiction field, they will ask us, after the training, who is going to hire me? There are institutions there that need the services of these people, but the level of ignorance is high. It's like they don't need these people. They need, but it's like they don't need. So because of this, people are afraid and they look at, if I go there because this field is not recognized, I will not be paid well. These are some of the fears. Finally, is the issue of stigmatization. You know, I look at stigmatization in two ways. Stigmatization on the part of those who are seeking the service, the client, stigmatization on the part of those who are giving the service.
Yeah.
Now, if you say you are addicted to drugs and you go for treatment, maybe when you are working, they will say they will sack you because you are not normal. The community will find it difficult to relate with you. And you also discover that if you do something, if you make a mistake, the mistake will be magnified. If you do something that is good, it will be underrated. Why are they magnifying that which is wrong? Oh, this person is not a normal person. And the service providers, for them to come in, is like if you are staying with people that are not normal, if you are working with them, then you are bound to behave that way. So even service providers are perceived in that way. As a result of this, it's a serious barrier, but we are hoping that with aggressive advocacy with time,
Yeah.
we can overcome some of these
Yeah.
challenges.
Thank you for that. You couldn't have said better what is happening, not just in Nigeria, but honestly in so many places around the world. And that's why, you know, we partner. That's why ICUDDR is here to partner, because these issues you mentioned of not having qualified trainers, of having institutional issues, of having stigma and fear, and, you know, all of those issues are right exactly what we're here. So I'm so glad to partner with you to work on these. We actually have an advocacy webinar that will be held tomorrow for ICUDDR. So it's just one of many issues you've said so eloquently. So thank you. And it leads to our last question for today, which is, how can stigmatization be a barrier to accessing drug treatment?
Yes, just like I mentioned before, stigmatization constitutes a serious barrier. There are many people that are dependent on drugs. But when they are thinking about going into a center for treatment, one thing that comes to their mind, what is it that people will say? What is it that will happen to me? As a result of this, people decide it's better, let me stay with it. Because of this thing, people feel that let me manage it. Until when it is coming to a point that they will not manage it, it's becoming a problem to the family. They want to kill somebody, the family will say, we have no choice, let's go. But because of the way they treat the society, the community members are treating these people and looking at them, they are not willing to go. And you see, that is why some of them, when they want to go to a treatment center, you know, Nigeria is just coming up. Drug treatment centers are still housed in institutions where they are treating psychiatric cases. And so at times when you want to take these people, they will say, no, but I am not a psychiatrist, I'm not having psychiatric problems. Why are you taking me there? But you see, it is a gradual something. Nigeria is developing. We are now establishing independent centers where it's only people that are dependent on drugs are treated instead of merging them with people who are having psychiatric issues. And so because of this perception that people will turn me as a psychiatric patient, then it is the barrier. That's one.
Well, once again, I just want to thank you for all the amazing work that you're doing and for partnering with us. And
Yes, thank you very much.
we will work again. We will continue to work together on these issues. And thank you for your time.
Thank you very much, Karen. I really appreciate it.